Welcome to Hospital Clínico San Carlos. My name is Javier Escanet. I'm head of the Interventional Cardiology Unit at this institution, and it is a great pleasure to introduce you to this exciting video on the shockwave technology. So what we are going to show to you is the result of a very interesting experience that took place during EuroPCR 2019. Shockwave actually realized that intravascular lithotripsy was playing a very diverse role and a big adoption among physicians all over the country. And here you can see some of the countries where intravascular lithotripsy has been used over the last 2 years. And what it was more interesting is that in addition to the number of operators and the number of publications that have been generated on intravascular lithotripsy, we also had witnessed a growing number of clinical scenarios, anatomical situations for the use of intravascular lithotripsy. And that was the main, reason, because during EuroPCR 2019, there was a contest of interesting cases coming from the community for those colleagues who are already using intravascular lithotripsy in clinical practice. And I had the privilege of being one of the members of the jury, along with good friends like Jean Fajadet, Jonathan Hill, and Carlo Di Mario. And we were thrilled and we were really excited about seeing all the cases that were submitted by the colleagues. I must say it was very difficult to decide which was the best one, but eventually we found a winner. And the winner is today with us, is my colleague also from Madrid, Alfonso Jurado Roman, who presented this excellent case that we are going to see and discuss now.
So thanks, Javier, for the introduction. I am going to present the case that we have entitled rotatripsy, combination of rotational atherectomy and intravascular lithotripsy for the treatment of severely calcified lesions. We present a 76-year-old male patient with hypertension, type 2 diabetes mellitus and dyslipidemia, who was admitted for progressive angina. He had a normal left ventricle ejection fraction without any regional wall motion abnormalities, and he underwent a treadmill exercise test that was positive for myocardial ischemia. The coronary angiography showed this severely calcified diffuse disease at proximal mid LAD without any other significant stenosis at other vessels. So we decided to perform our PCI bifemoral approach using an extra backup guiding catheter 7 French and cross the lesion with a Sion black guide wire over a Charmpike microcatheter. And anticipating that we would need higher support, we exchanged this wire with a Sion blue extra support 1. After that, we tried to predilate the lesion with an NC balloon 2.75 millimeters at height atmospheres, observing this dog bone image showing a clearly under expansion of the balloon. Afterwards, we analyzed the lesion with IBUS that confirmed the severity of calcification with 360 calcium rings at several points.
So, Alfonso, at this point, may I ask you, to what point do you think that the use of intracoronary imaging can help you in deciding the next step in treating such a calcific vessel like this?
I think it's a key point, intracoronary imaging in all PCIs, but especially in complex PCI and the calcified lesions especially, because you need to know the severity of calcification in terms of the circumferential of knot of the calcified plaques, and even the dip of the calcium to choose non-compliant balloons, scoring balloons, rotational atherectomy, laser, or intravascular lithotripsy.
So the suggestion is that for the colleagues is that if they can image, that would be great. If they cannot go with the IBUS catheter, that probably is also a proof that you have ahead something that needs severe or very intense plaque preparation.
Yeah, perhaps you need to predilate with a small balloon, 1.5 or 1.75, and then try to introduce the IBUS catheter or the OCT, because there are some problems as well with the OCT.
So what we can see here, I mean, clearly it's beautiful to see that here you have a true napkin ring of calcium that goes all the way around. I mean, obviously we are seeing here that the thickness, if each of these markers is about 1 millimeter, and of course, I mean, you have echoes, so it can be even deeper than that, but certainly you can anticipate that it is more than 1 millimeter thick.
I think it's difficult with IRIS. It's difficult to know exactly the deep of the classified lesions, but it's the first imaging technique we use at this case.
Yeah, very nice. Thank you.
So after this imaging, we decided to perform rotational atherectomy with the RotaPro system, starting with a 1.25 bar. As you can see here, we did 3 or 4 runs and complete the ablation. And afterwards, we tried to dilate with the same NC balloon of 2.75, observing nearly the same image of clear under expansion.
And this was very high pressure. I can see 26
atmospheres like we did previously. And after this imaging, we tried to upgrade the bar size to 1.5 bar, did again the ablation, and tried to dilate with a slightly higher, bigger balloon in the next slide, of 3.0 NC balloon at high atmosphere as well, with a slightly better expansion, but
you can still see a huge waste over there.
Yeah, of course. So at this point, we decided that we needed anything else, and we tried to perform intravascular lithotripsy with a 3.12 shockwave balloon, and we found some difficulties to deliver the balloon towards the target lesion, and we performed an anchoring balloon technique, inserting another guide wire at the diagonal branch and inflating a 1.5 semi-compliant balloon at that branch. And after delivering the shockwave balloon, we did the pulses.
So this is very interesting because I think that obviously illustrates perhaps one of the interesting aspects, that here you have 2 wires, something that of course you could not do before when you were doing rotational atherectomy. You can use 2 wires. To what extent do you think that this contributes to the safety of the procedure, the ability to perform in-depth modification of plaque while protecting a bifurcation? And also, on the other hand, do you think that it may interfere with the working of the device?
I think it's a great advantage of IVL, of lithotripsy, because sometimes you have to face with bifurcations. We all know that protecting the set branch is mandatory in these scenarios, and this is quite limited with rotational atherectomy. So this case shows that you can protect that branch and even do different strategies as anchoring balloon that help us to deliver the shockwave balloon towards the lesion.
Very interesting, thank you.
So after delivering the balloon, we apply 30 pulses at the undilatable lesion here, and the other 50 pulses in the proximal mid-segment of the calcified lesion. And afterwards, the shockwave balloon complete a good expansion at 6 atmospheres. So after this, we confirm the results of this combination of rotational atherectomy and lithotripsy that we have called rotatripsy with an OCT pullback. And you can see here the fractures of the intimal calcium and the medial calcium produced by both techniques. And in the next slide, you can see, perhaps better in the still pictures, the combination of the effects of these 2 techniques. Here in the asterisk, you can see the focal ablation of the intimal plates produced by the rotablation, the places which bar contact with the intimal calcium. And here the arrowheads show the deep fractures that IVL produces in the calcium, the middle calcium.
So this could be the erosion that you have caused by atherectomy, probably, this here? By rotational atherectomy, you can see it also there. But as you mentioned, you have also the effect, a specific effect of these cracks caused by which of course explains why only with 6 atmosphere the balloon opened. I mean, it is not that the balloon is actually making a higher pressure than 24 that you were using before. It's that you had modified in depth the plaque, and then only with 6 atmospheres it was possible to open the vessel.
It was shown that intracoronary imaging is a key point to confirm that you have cracked the calcium, that you have modified the plaque before implanting the stents. It's another good point of intracoronary imaging in these settings. So after confirming this, we could implant 2 overlapped stents without any difficulties, and achieving a good angiographic result that was again confirmed with OCT imaging with good position expansion of our stents. So our take-home message of this case perhaps could be that rotational atherectomy allows the treatment of intimal calcium and permits to cross balloon and stents through severe lesions. However, it may not be enough to achieve adequate expansion of these devices if circumferential deep calcium plaques exist. So intravascular lithotripsy poses, in my opinion, a revolutionary tool in these settings to treat deep calcium and dilatable plaques, and the combination of these 2 techniques in a cross-hole and undilatable lesion that we have called rototripsy may be useful in this context.
I think thank you very much, Alfonso. It's again great to see the presentation again, because one of the messages that obviously reached the jury, the members of the jury, was this very important concept of the synergy of plaque preparation techniques. Sometimes, some colleagues may have seen these techniques as sort of competitors or dissociated alternatives, but what your case demonstrates, and it's also supported by our own practice actually, is that in some situations you are much better off if you modify initially the plaque and you are also able to open channel for the interlithotripsy device, and then to perform a much more in-depth modification of the plaque, which also in your particular case was performed safely because you had the possibility of having the 2 wires in this bifurcation, which is very nice. Could you comment something about other scenarios, clinical or anatomical scenarios, where you have found of interest or of use the lithotripsy?
I have only worked with lithotripsy in this kind of a scenario, in deep calcium plaques, the left main bifurcations, where other studies have some limitation, as you have told, because you can use another guided wires to protect the side branches. And I haven't practiced with lithotripsy in the structural heart interventions, but I know these are another scenarios in which lithotripsy could be a good option to access by femoral approach, the TAVIs, and all these procedures.
Now, in case that you don't have, we made a lot of emphasis on imaging, but in a situation, of a cath lab that does not have available intracoronary imaging, do you think that still you can use lithotripsy? Will you make any recommendations on other tools that you can use to guide the procedure?
Yeah, of course. Imaging is quite a good option to confirm the result, to choose the strategy. But if you don't have imaging, I think we have do pretty the same strategy, because you observe in the first coronary angiography severely calcified lesions, and you try to dilate with the first NC balloon, and you watch clearly under expansion of the device. So you use the rotablation to make a channel, and you need something else to dilate the deep calcium plaque. So perhaps when you have this calcification in the angiography and this image with you try to dilate with an NC balloon, intravascular lithotripsy is the option.
So an important message is, if you see that your balloon is unable to open the plaque, make sure that you choose an adequate way of expanding the balloon, lithotripsy balloon, before going to stenting.
Of course.
The concept that you will implant the stent and later you will be able to open the stent once it's implanted, because theoretically it should be safer and so on, it doesn't work. That's an important message that we can also share with the colleagues. I also noticed that you were, in a way, looking with several projections, I believe, to the inflated balloon. I noticed that you were also looking in different angulations, which is also a very important aspect. Now, what do you anticipate that will be the future, the immediate future? Where we move on from now, from here?
In my opinion, that my experience is limited, but I think it's a revolutionary tool to treat calcified lesions. But it's not a competitor with other techniques. As you said, we have experience with rotablation, with laser in my center, and I think they are complementary tools. But if you have undilatable lesions with deep calcium, I think IVL could be the best option in a short time.
Well, Alfonso, thank you very much for sharing this great case. Congratulations again, because as I say, there were very good cases, but we were really delighted and interested with your case. And that's all from our side, and we look forward also to getting more insights from the colleagues that are using this new technique that obviously opens completely different possibilities in addressing patients with severe calcific lesions in the coronary arteries. Thank you.
Thank you.